It's my pleasure to welcome you once again to today's webinar on how to build a medical home. The Alameda Contra Costa Medical Association is pleased to partner with the California Academy of Family Physicians to present today's program and would like to welcome our three distinguished presenters. Dr. Larry Shore has been practicing family medicine in San Francisco since 1981, attended the Mount Sinai School of Medicine in New York, and completed his family practice residency at the San Jose, now O'Connor, hospital program. Dr. Shore has been actively involved in the transformation of his current practice into a patient-centered medical home, sponsored by Brown & Tolan Medical Group, and will serve as lead physician of new practice, My Health Medical Group. Leah Newkirk, JD, is the Director of Health Policy at the California Academy of Family Physicians and is a graduate of Harvard University and the University of Pennsylvania Law School. Ms. Newkirk is heavily involved in healthcare reform implementation, patient-centered medical homes, and health information technology advancement and payment reform. She manages the Government Affairs and Medical Practice Affairs departments for CAFP. Chase Gray has worked as an RN in a variety of healthcare settings, including adolescent mental health, clinical research, developmental disabilities, and most recently as a quality improvement coordinator for a home health agency. Ms. Gray has worked at Health Teamwork since 2010 and serves as the director of the Patient-Centered Medical Homes Foundations program. Under her leadership, the Foundations program has grown from 52 to 210 practices. Welcome to all three of you. Let's get started, I believe, with Leah.
Thank you, Joe. Again, this is Leah Newkirk. I'm the Director of Health Policy at the California Academy of Family Physicians. Thank you for participating in this webinar. CAFP and the Alameda Contra Costa Medical Association are thrilled to be bringing this to you. I have been presenting on the medical home concept for 3 years now, and I think the tide is really turning. There is recognition of what it is. We're seeing policies come into place that support this model. So it's a great moment to be thinking about how to build your medical home. My goals, my presentation is going to be focused on defining the concept, what is the medical home, talking about policies and payment that encourage support for medical home development, why you should be doing this. And then I'm going to give you some evidence from a Fresno, California medical home pilot that CAFP developed with partners there. And I see this as sort of an arrow in your queue. One of our goals with this webinar is to give you information that you can take to your infrastructure, your hospital, your ACO, your IPA, to say, listen, I need support to transform my practice, and I need support to sustain myself as a medical home. So we want to give you the research, the evidence that supports the model. So to start, what is a medical home? This timeline shows you that it has sort of longer roots than you might expect, and that we have the pediatricians to thank for the concept. But the bottom line here is that by 2008, the American Medical Association and the largest primary care associations moved to advance this model, and it coalesced around what are called the joint principles on the patient-centered medical home. And here they are sort of distilled. There's a personal physician directing a team. The practice, the medical home practice, has a whole person orientation or is patient-centered. The physician and team are acting as the quarterback in a complicated healthcare system. They're coordinating and integrating the patient's care. So they know when their medical home patient has been hospitalized and discharged or is at the pharmacy. They're coordinating that care. The medical home is always improving quality. The medical home has enhanced access, and payment supports the medical home. So these are the ideal, the principles. And it's still a little abstract, those principles, so I want to dig into it a little bit and focus on some key components. Increased access, I think that has a couple dimensions. There's increased access in the medical home, both in the sense that there are after hours, there are new ways of scheduling, open access scheduling, but there's also the use of technology to increase access. You have access to your medical home team through email, through telemedicine. When you have a problem, you can access your medical home rather than go to the ER. Population management is another key attribute. And this model is known to better manage chronic illnesses. So you're using your registry in the medical home or your EHR to identify your diabetic population and proactively reach out to them and manage their care, bring them in, as opposed to waiting for an illness to get so bad that, that they come to you. The physician-directed team approach, the team piece of this is important. In a lot of medical homes, there are new staff positions. There's a care manager working with the most complex patients. There can be a quality improvement coach working on QI. There is also frequently a use of the lean model so that every team member is working at the top of his or her license and working efficiently. So there's less duplication of effort in the medical home. Again, that continuous QI is important, and the medical home is using data to see where their weaknesses are and where they need to improve. Technology is a big piece of this, having your registry and EHR in place and using it to the maximum level possible. And then that service-oriented culture, the patient-centeredness. I work for family physicians, and they are almost across the board. They are wonderful people. I used to work for lawyers, less so. Family physicians are great people. They're patient-oriented. But in the fee-for-service world, they are frequently on a hamster wheel, and it's hard to be patient-oriented in that culture. This model changes that. And there are aspects of it. Even the architecture of a medical home office space can be redesigned to be patient-oriented. So the evidence is in. This model works. It improves the management of chronic illness. It improves care for all patients. And that improved quality results in better health at lower costs. And really what that comes down to is reduction in inpatient days and ER visits, and this is where we're seeing cost savings. So again, this is another arrow in your queue. Patient-centered medical homes have resulted in incredible cost savings for payers. So bring your payers to the table and show them this evidence. These are three prominent examples of medical homes. They are large integrated groups. I'm going to show you our Fresno pilot, which is a smaller group. There are lots of other examples outside of these three. So policy. My main point with policy is that the medical home aligns with a lot of other state and national trends. I look at the healthcare reform law on a daily basis. It's a 950-page law, tens of thousands of implementing regulations. It's overwhelming. What I would advise physicians, primary care physicians, is to focus on this model. It will ready you for a lot of other healthcare reform, a lot of other healthcare trends that are coming into play. So, for example, healthcare reform is going to increase emphasis on quality reporting and transparency and on value-based payments. Well, the medical home turns you into a high-value physician and gives you the tools to report on your quality. Medical home is aligned with meaningful use. The NCQA, patient-centered medical home recognition, is beautifully aligned with the Meaningful Use program. And medical home is aligned with accountable care organizations. They need to meet that triple aim of quality improvement, improved health, lower cost. And the medical home is the way to do that. I think that there's broad recognition of that fact. So payments. This is the ideal. Well, historically, let me start with historically. primary care physicians have done a ton of work that is not compensated. The medical home model actually asks physicians to do more of that historically uncompensated care, care coordination, coordinating the patient's care in the healthcare system, adoption and use of HIT. So the medical home requires, we think, a new payment model. And CAFP has adopted this as the ideal, the blended payment model. This includes fee-for-service, but also a second non-volume-based payment. Usually it's a PMPM, a per member per month, but it can be a quarterly payment that allows you to do the care coordination, increase your access, increase your use of HIT. It also, the ideal payment model has a payment that aligns everyone's incentives, a bonus payment for metrics achieved or for cost savings achieved. So that's the ideal. The reality is that we're not there in California. I'm sorry to deliver that news, but I think that there are a lot of signs that this is coming, and you have to think about the fact that transforming your practice takes some time. Dr. Shore and Chase will talk more about that. But last year, several of the largest national health plans announced that they are going to be paying medical homes more. For example, Aetna said they're going to be giving additional payments to NCQA recognized patient-centered medical homes, or they're going to pay enhanced payment for high-value primary care practices. So this they rolled out in other states first, and many of them have said we're going to roll this out nationally through 2014. It's coming. There are other places that are putting pressure on payers to change the way that they're doing things too. One example is the Office of Personnel Management. This is the branch of the federal government that's the employer, the human resources arm of the federal government. They've got lots of employees. In their last request for bids from health plans, they said, tell us what you're doing plans to support the medical home. Tell us what percentage of your networks are medical homes. Who are the medical homes on your network? Well, Covered California, which is the developing California Health Insurance Exchange, followed suit. In their model contract, they say the same things. Tell us what you're doing plans to support the medical home model. Tell us what percentage of your networks are medical homes. Identify them for us. So this puts pressure on the plans to support this model, and is a good sign. We wish that they required it, but it's a good sign that things are going to change moving forward. Employers are another potential partner for you. Our employer, our payer in the Fresno pilot is an employer, a self-insured employer. You know, they have collectively bargained agreements sometimes. They want to drive down costs, but their hands are tied when it comes to benefits redesign. So this is a way for them to work around that. And then Medicare. Many of you might know under healthcare reform, there's going to be a value-based payment modifier attached to Medicare payment in 2015. So if you're a higher value physician, meaning you have higher quality at a lower cost, in 2015 you're going to be paid more by Medicare. So this is a Fresno pilot. This is the evidence, the local, California evidence I want you to have. It's an 18-month pilot. It's ongoing. It's pretty small, a 45-provider group. Only 2,700 patients are included. We have that blended payment. That's the great news. This is the first, I think this is unique in California, that fee-for-service, PMPM, and then a bonus payment for metrics achieved. One of our highlights has been working with Health Teamworks, and you're going to hear from Chase Gray. They helped us design this pilot. They coached the practices to the medical home model. They coached an internal staff person to be a QI coach going forward to sustain the work. It was just a delight to work with them. But I think the physicians have also been very happy with the payment and the conversation with the payer about goals. And then they have these new staff roles, the QI coach. They have a complex case manager dealing with the 700 top most high-risk patients in their practice. And these slides will be made available to you. I'm going to flip through them quickly. My great news is at 6 months, we saw improvement in every metric except one in this pilot, and we saw savings to the tune of $1.8 million, and this is for a payer who invested $450,000 over an 18-month period. So this is great, and this is local evidence. So contact me. I will give you this data, and you bring it to your payers, your ACO, your infrastructure to support your transformation. So this slide just says CAFP has drunk the Kool-Aid. We want to advance this model in the state. We think it strengthens the primary care profession, and our board has directed us to provide services that support primary care physicians, our members, as they transform to the model. We have a great website. We have some tools already, but what we want to do now is make Health Teamworks available to every California physician. We also have another partnership with the California Primary Care Association. They have a web-based tool that allows you to get to NCQA recognition, and it's terrific, and they have coaches. So I have to end my presentation, but my bottom line is contact me. Tell me where you are in your medical home development, and let's figure out how CAFP can help you, what kind of services you need, and how we can help you get them and build your medical home. Thank you very much.
Terrific. So I believe Dr. Shore is up next.
Thank you. By way of a brief introduction, I am a family doctor practicing in San Francisco for quite a while, and I became curious about the patient-centered medical home about the time that the joint principles came out. And I have to say that I went from being confused to curious. I began making a transformation in my own practice about that time and got to the point where I realized that I needed additional help to get to the next stage and to be able to actually realize a patient-centered medical home. So these are some of the things that I'm going to talk about today. The actual process, of course, is quite involved, and we were fortunate also to have Health Teamworks as our consultant in moving forward with this project. So we're going to talk a little bit about the definition. I'll repeat some of what Leah said. We'll talk about some of the work models within the newer practice. I'll show how we're trying to address the triple aim, talk about some of our results so far, and then a little bit about what's next for us. So this is a very simple graphic about the patient-centered medical home, and it reiterates some of the things that Leah said. I like the definition. I'll just read it out loud. The patient-centered medical home represents a healthcare relationship between patients and their physicians. Care is facilitated by provider teams, chronic disease registries, advanced information technology, and other means to ensure that patients get coordinated, comprehensive care when and where they need it. It's really a customer service-driven model, and I think that really resonates well with being a family doc and being in primary care all these years. And then there's a nice quote at the bottom from Robert Wood Johnson as well. So the history of our practice, which is called My Health Medical Group, began with a proposal to the Board of Directors of Brown & Toland. Brown & Toland is a local IPA in San Francisco that's been in business for about 20 years and has been involved in several innovative transformations in healthcare delivery. After the initial proposal was approved, 45 doctors were invited to review the proposal. The most common reaction was, sounds interesting, let me know how it works out. Subsequently, an office manager was chosen, and 4 physicians were selected to start the practice, which started in March of last year. The initial practice had 2 internal medicine physicians and 2 family practice. We had a social worker, we had a care manager, which is a really important part of the model, a data analyst, which is also a key member, and then the various support staff who are undergoing role transformation as well. Today, we've made some small changes in our model. We are now expanding our teams to include a physician and a nurse practitioner, supported by 2 or 3 clinical medical assistants who are functioning in an expanded role compared to the traditional medical assistant role. A care manager oversees both complex, what we might call transitions of care patients, recently hospitalized, recently in crisis. In addition, she also leads our population health management efforts and is coordinating our outreach, which has really gotten started recently. The data analyst has been wrestling the beast of all scripts and trying to use new software to extract data to let us know, how we're doing and where we have opportunities for improvement. So this is another graphic that I borrowed from Southern California, and I like it because it talks about many of the same things that Leah mentioned earlier. We're going to focus a little bit on access and population management, but all the points here are quite important, and most important is the purple one at the bottom, patient and family. So in terms of our staff, we have seen the medical assistants take on a much more expanded clinical role than they had done previously in a more traditional practice. And we're finding our other care members of the team doing things like phone outreach and coordination of care, again, outside of the normal role that you might expect in a private practice office. The physicians are taking on a role that, as Leah described, is much greater than it was before, although currently uncompensated, and that is to take on population health management. Part of population health management is to start the day with a patient huddle. Patient huddles are part of what's called InReach, where you look for gaps in care, and the planning for that is done by the medical assistant the day before the visit, and then the morning of the visit, we go through all the opportunities to catch up on things that need to be done in addition to what the patient is actually coming in for. The last part of this slide talks about supporting self-management, and this is a really important part of the patient-centered medical home and one that we are continually working to understand and improve on. We see the new team redistributing the roles somewhat, with the physician focusing more on the sick and unstable, the nurse practitioner looking more at the stable, chronic, and doing a larger share of the preventive and screening exams, with some overlap in urgent care. And then the care manager, along with the clinical medical assistants, as I mentioned before, doing a lot of the outreach and focusing on the transition of care patients, which are, again, the most unstable of all. So here are some of our newer workflows. The team huddle and care planner I mentioned before. The clinical medical assistant is now starting the patient note on the electronic record. And this is essentially getting the chief complaint and organizing and presenting for the physician to then take the visit to the next step. We ask our patients to reconcile their medications list by giving them a printout, and this has been very helpful, particularly in patients who are highly complex and see multiple other physicians. An action plan is a specific type of contract between the provider and the patient where you come together to make a jointly agreeable and realizable plan for improving healthcare. Clinical summaries, of course, are part of meaningful use, and we do one of those for each visit. This is a summarized version of the visit that the patient gets either by electronic means or by mailing. Open access was really an important part of our initial efforts, and I will talk more about that. Extended hours is what it sounds like. Brown and Tolan also, at the same time, created an after-hours clinic, which I think has been a real nice addition to the community, and it's open to all patients in San Francisco. We also have a new patient portal, which is part of Access, and we do a very good job, I think, of reporting clinical results to patients in a timely fashion. Building blocks is a concept that has been around for a while, and it says that you can't really know about your population until you know exactly who your population is. So defining your patient panel is an important first step. And some of this writing comes from Tom Bodenheimer at UCSF, and we followed a lot of his writings over the years, and I think he's been an inspirational leader for us. So what we do is we scan the medical record to find where the patients are going. And once we have found where they're going, that becomes your patient, part of your panel. The literature suggests that A full panel would be about 1,800 patients using this U18 convention, which is unique encounters in the last 18 months. If you use a larger time frame, you'll get a larger panel, but they may have shifted care. We also are borrowing from CMS in terms of their ACO algorithm to determine who within the practice is actually taking responsibility for that particular patient. And then we have started adjusting our panel capacity by using a measurement tool within Allscripts, our electronic medical record, called Care Analyzer. Care Analyzer can assess each patient's relative risk for needing care and assign individual numbers. We can then get aggregate numbers for each of the teams. And using that, we created a formula that looks complex, but it's actually kind of simple. And it adjusts the panel capacity based on the FTE status of the providers and the complexity of their relative patient panels. So the two examples here is that a physician who is working part-time with a nurse practitioner part-time, taking care of an older and sicker population, would have a smaller panel capacity, in this example, 2,100 patients. A full-time doctor with a full-time nurse practitioner taking care of younger, healthier patients would have much larger panel capacity, and we would adjust our staffing accordingly. At My Health Medical Group, we've had several goals to work on since our inception. The first ones are the ones that guide us, of course, the triple aim: improved patient experience, improved patient outcomes, bending the cost curve. We have some additional local goals. We wanted to be the first NCQA Level 3 PCMH in the Bay Area. We wanted to have our performance, particularly on clinical items, at or above the 75th percentile using IHA, which is our local measurement tool that a lot of paper performance is based on. And we also wanted to succeed on Press Ganey, which is the patient satisfaction questionnaire that many hospitals and medical groups use throughout the country. We had an ambitious goal to break even by 18 months. We also wanted to bring a new primary care physician to San Francisco. San Francisco has an aging primary care population, and we're not doing a very good job of replacing ourselves, at least in the non-Kaiser, non-UCSF world. And then ultimately, of course, we want to spread our best practices to the rest of the primary care network in Brown and Tolan. So here's an example of a project around patient experience. Access is a very significant issue in primary care offices, particularly when the practice is oversubscribed. So we looked at where we were. We found that we were not doing so well on access for urgent appointments using the third next available convention. So we started out with our baseline data, and then using the Plan, Do, Study, Act approach, which is continuous quality improvement, we put down some ideas about what we thought might work in terms of improving our access to care. We were able to demonstrate a rather substantial improvement on access using the third next available appointment metric from 13.5 down to 4.3 days. And this made our patients happier, and it really made our schedulers happier because they were able to say yes much more frequently. I think each practice will come up with their unique solutions in terms of access, but these are some of the basic things that we read about in the literature and we borrowed from. Since that time, we've actually done even better on third next available, and we have been able to demonstrate that our patients who call in the morning can be seen that day at least 85% of the time, and most of the time higher than that. The after-hours clinic has been particularly helpful as well, so our patients really can always get in the same day, and we're open on the weekends too for the after-hours clinic. And we seem to be scoring fairly well on the Press Ganey measurement, which is reassuring. Clinical outcomes is another very exciting part of this project. Brown and Tolan has added additional software to Allscripts, most recently Humedica, which allows us to create patient registries even though our patients come from multiple different payers. So this is not just the HMO side, but it's all payers and all patients who come to our practice. Here's an example of a diabetes dashboard. And what this does on a quarterly basis is look at several different performance indicators in diabetes, and these are very common ones that everyone looks at, and then breaks down performance against the benchmark. The benchmark is the green horizontal bar. Our goal is to have each team at or above that bar, which would then represent performance above the 75th percentile. This graphic represents that we're doing okay, but we identified right off the bat there was one thing that we weren't doing as much as we would like to, and that's monitoring for nephropathy in diabetics. bending the cost curve. So Leah showed some very exciting data from Fresno. We believe that we have similar data. We're just not ready to talk about it publicly yet. But I am encouraged that we are heading in the right direction, and we should be able to show benefit from all of these initiatives. Generic prescribing can have a tremendous impact. In Brown and Tolan, it's been calculated that if we reduce, well, let's say if we increase our generic prescribing by 1%, it saves $750,000 per year. It's a staggering impact. So fortunately, we met our first goal. We were able to get level 3 recognition from the NCQA in February of this year, and we were almost the first in the Bay Area, with Petaluma just being slightly above us, but those of us in San Francisco are uncertain whether Petaluma is actually part of the Bay Area or not. And we were also honored by CAFP, which was very nice. So what's next for our practice? Well, we have several things to work on. We would like to round out our healthcare teams. We really would like to recruit a new family doc to our practice to round out the space. We're working hard to increase our patient portal enrollment, and I think the portal sells itself, so that's going to be fairly easy. We want to incorporate more patient input into our continuous quality improvement, and we've just gotten started on that. The medical neighborhood is a huge project, and this, of course, refers to identifying those specialists who are most able and willing to do shared clinical management on patients. And, of course, we want to spread the workflows of advanced primary care and the PCMH to other PCP practices within Brown and Tolan. My patients often ask me how we think we're going to do under Obamacare and the changes to come in the coming years. And I think we're going to do okay. I think that for anybody who used to be in private practice, this would be a good thing to look for in terms of your future, to both do the right thing and to have more fun doing it. Thanks very much.
Okay, thank you very much, Dr. Shore. My name is Chase Gray, and I'm a regional director at Health Teamworks. We're located out of Denver, Colorado, and I am absolutely thrilled to be here today to play the supporting role, essentially, in the great stories of what Dr. Shore just explained, what was going on at Brown and Tolan, and also the Fresno story. Just a little bit about who we are at Health Teamworks. This slide really, gives folks an opportunity to take a look at what our mission is and really what our goals are. But I think the most important thing for everyone to understand is that, Health Teamworks is an organization out of Denver, Colorado that is a not-for-profit organization, and we've been around since 1996. We actually started out in the development of summarizing clinical guidelines, really for primary care providers to use as a point-of-care decision support tool that was very paper-based back in 1996. We currently have a very active guidelines department that is still collaboratively working in the state of Colorado to summarize national guidelines and develop those and other supporting tools. Back in about 2008, we had the opportunity to participate in one of the kind of first national organizations improving performance in practice. Colorado was one of the first states to become involved in that project, and that was kind of our first foray into some of the elements of patient-centered medical home. That program was really having primary care practices make sure that they were looking at chronic disease management, having elements of population management and registries in place, also looking at how to engage patients and families a little bit differently in their care. And then the other concept that was part of that was really about having a practice facilitator or a quality improvement coach to help primary care offices and practices really implement some of these new concepts. Health Teamworks then in 2009 was the convening organization for one of the patient-centered medical home multi-payer pilots. So our experience from the initial pilot moving into the patient-centered medical home multi-payer pilot has given us quite a bit of experience in the implementation of medical home and of practice coaching or practice facilitating. So what is practice coaching? Coaching really provides the technical assistance to practices or larger systems even in the transformation process to become a patient-centered medical home. Our organization's expertise and our coaches' expertise is really around the implementation aspects of those elements that Leah covered in her slide deck and that also Dr. Schor had talked a little bit about in their experience. So we really support practices and teams around how to go about doing that and making those concepts come to life. One other thing about what we do, we are very dedicated to supporting practices to learn how to do the work themselves and really begin to experience how to become more resilient to everything that's going on within our healthcare system here in the U.S. as that delivery really continues to change. So this is you know, what Health Teamworks is really being requested to do all across the country at this point. In the state of Colorado, where we are, I had mentioned the multi-payer pilot. That was a pretty small pilot with 16 practices, and that is now completed. But the other programs are very active in our state right now. We were also chosen as one of the states to participate in CMS's Comprehensive Primary Care Initiative. There's 59 practices there. We have another program that has 101 other active primary care practices, and then we also have you know, the family medicine residency program at all 10 sites throughout the state. So all of those practices that are mentioned on this slide deck in the state of Colorado are receiving active coaching, meaning active facilitation and active implementation of those elements of the model. So that's what we have going on in the state of Colorado, and then we have been very busy in terms of spreading our wings as the demand for services of implementation, transformation to patient-centered medical home, really looking at, you know, how systems and then even individual practice sites really do this work. These are the states that we're currently providing services to, and here in the state of California, I have had the distinct opportunity and pleasure to kind of work in a lot of the communities here. This is my region. I worked on the Fresno project, as Leah had mentioned, and am familiar with the work that Dr. Schor is doing. Just to let the audience know, other communities that we're currently supporting here in the state are in the Inland Empire area, San Diego. We had a project in Orange County. I am in Mariposa, California today, and then we also had a residency project at UCLA Harbor. So there is a lot of momentum in your state, and it's really a true pleasure to be working with these different communities, systems, and also individual practices, because you know, those are really the folks and the people who are doing the work to provide services to the people who receive them. So we're very proud to be a part of what everyone is doing here. Just to go back to the concept of coaching, and Dr. Schor had mentioned Tom Bodenheimer from UCSF, and I'm not sure if folks had seen this issue brief, you know, from the Commonwealth Fund, but what this really talked about was the support of having coaching or having a practice facilitator support some of the implementation and transformation aspects to patient-centered medical home. We're starting to see a lot more support around this because it's really difficult for practices who are trying to do everything that needs to be done in a very busy family practice, internal medicine practice, pediatric practice, and then also begin to really look at, you know, how do we make improvements, how do we pay attention to quality metrics, how do we look at staffing, at panels, how do we do outreach, coordinate care, all of these really complicated, complex types of things that the medical home model is asking practices to pay attention to. So practice coaching, there's becoming a lot more support for why practices really need this. Dr. Schor had also mentioned the triple aim. Really the work that we do at Health Teamworks and the initiatives and what we get involved in is also very relevant to being able to pay attention to outcomes for patients at a population level, really looking at satisfaction within the experience that patients and families have, and then also looking at cost. So all of our programs and support are really around these larger concepts. Oh, these are going to pop up individually. The elements of the patient-centered medical home had been listed a little bit in previous slides, but from our perspective, you know, what we help folks do is really begin to sequence how these need to be implemented at each individual practice site. We go through somewhat of a rigorous assessment process and then work together with the practice to decide, you know, what areas really need to be focused on first, and help a practice kind of sequence the implementation aspects. For those practices that are on today who this might be, you know, a little bit new information for, what I have done is kind of starred the concepts on here that are really the foundational pieces that practice should be thinking about, you know, if they're wanting to get started on some of this stuff. So looking at your own leadership and culture and readiness to begin transformation is so important. Really making sure that evidence-based guidelines are part of the consciousness of a practice. If you're in a large provider or multi-provider practice, making sure that there are common evidence-based guidelines that are being used at your site are important. How are they embedded into your electronic health records? How are those tasks maybe being divided up against staff members for when patients come in? Population management was also mentioned. If you don't know, you know, who your population is, if you don't know how many diabetics you might have, if you don't know how many cardiovascular disease patients you might have, it's really difficult to do some of the high-risk, complex case management type of services that were discussed in previous slide decks. So population management and having some of that initial health information technology in place is really one of the first steps for practices to begin looking at. Team-based care is paramount in patient-centered medical home. What we talk to practices about is that this is not just about having the right people in place, but it is truly exploring the different tasks that need to be done for patients coming in. So covering prevention services, covering chronic disease management, those types of things on top of acute issues that folks might be coming in for. Team-based care and ensuring that your panel of patients and who is being seen either by a physician versus who's being seen by a mid-level, maybe what tasks can be accomplished by nursing staff and MAs, and delegating that appropriately according to licensure is really what true team-based care is about. And it is so necessary in the patient-centered medical home model. Just being able to divide that out appropriately will allow practices to really become a little bit more efficient in their daily work lives that they have, and also a little bit more effective in what they're trying to achieve for their patients. Really, patient-centered medical home for practices and providers and staff, you know, this is a paradigm shift when it comes right down to it. It's kind of going from looking at the singular patient to thinking about more population-based or panel-based. It's really about changing from the thought of a patient and more of a hierarchical relationship to a partnership with patients and families. It's kind of moving away from the decision maker being the lone provider or lone physician to more of that team-based care delivery that I had talked about. It's also moving away from, you know, ultimate authority of one individual to maybe some shared decision making. Again, making sure that healthcare is truly patient-centered and that shared decision-making is going on. It's also moving from acute and episodic care to really planned care, and making sure that care is proactive and that it's whole person centered. The other paradigm shift is moving away from maybe variation in how chronic diseases are managed or prevention services are managed to relying more on those evidence-based types of guidelines and having clear protocols in place. So for a lot of practices that are starting out and thinking about transformation, a lot of this is culture change, and a lot of it is really a big paradigm shift for folks. What we try and do is bring this down to a level that people understand, and this is a quote from one of the practices we work with in Colorado, and the quote is from a front desk. And after all of the discussion about what is patient-centered medical home, the elements, the definitions, they said it very simply, which is, it's the kind of care that you'd really want your mom to have. So, it's high-quality care, it's safe, it's continuous, coordinated, comprehensive, and there's that partnership. So I thought that was said very nicely. A couple of things that we have learned in terms of practice transformation and the work that we have done at implementing the elements of patient-centered medical home is that these elements cannot really be achieved just through the implementation of new technology. Technology, EHRs, all of these sophisticated systems absolutely support and are aligned with what we see in patient-centered medical home, but it's not merely the solution. And for those of you that have electronic health records or that are using technology, you know that there's just as much change and upgrades involved in those systems as well. So you can't always rely on them being the solution. Recognition, some recognition programs were also mentioned in previous slides around patient-centered medical home. So NCQA is one. The Joint Commission also has another recognition program for patient-centered medical home. Even though those recognition programs are very important for practices to achieve, it doesn't always mean true transformation. So we look at transformation as being alive and well in the practice every day for every patient. So even though the recognition programs are becoming more and more important for practices to achieve, we like to look at true transformation and sustainable transformation. This is a lot of work. Dr. Shore talked about all of those things that they had achieved and that I know working with the Fresno practices that they achieved. This was not without dedicated time and resources at multiple levels for them to do this work. So carving out that time, being prepared for that time is also a really important aspect for new practices to consider. The other reality is that practices have many, many competing priorities today. So let alone just seeing their patient caseload on a daily basis, there's so many other things going on for primary care practices and systems in healthcare right now. So there's competing priorities that do exist for practices and teams. The other thing with patient-centered medical home, there are many unexpected turns that can occur and do occur. It's just the nature of kind of the healthcare business. The goal for us, and when we work with practices, is really to try and get some of these elements around PCMH and continuous quality improvement to become more of a cultural aspect for practices that is really more on the front burner of priorities. It becomes sustainable for the long term. So that's kind of what our goal is in terms of transformation, is that even though there's bumps along the road, that practices become more resilient in how to handle them. Another quote from one of our practices, as they get moving through implementation, I love this one. It was that they realized that PCMH is not just a diet, it's actually a lifestyle change. So this just proves kind of the other quote on here, that change is a continuous process and not one static event that occurs. Some of the measurements for us of success when we work with systems or practices are varied. What I want to focus on the next couple of slides really has to do with data. Leah had presented some of the cost data that was involved in the Fresno project, And Dr. Shore had showed some practice level data around quality measures. And I think what I can tell you all, coaches or the facilitators, really work with practices around practice level data, even provider level data to help make improvements. So, when you do quality improvement, if you can't measure it, you don't necessarily know that you're making improvements. So having data, whether it's satisfaction data, whether it's cost data, whether it is clinical quality measures, really having the availability of this information at the practice level is so important for coaches to be able to help drive some of this forward. So this is just an example of some asthma data and having, making sure patients had an action plan in place. You can see that this particular practice, when they started out, were around 30%, and after a series of months, they were able to get up above the goal line. The next couple of slides are programmatic level, so aggregated for, this was the PCMH pilot, so this had 16 practices involved. Again, it's looking at trying to coach them to goal on some of these measures. Again, this is 16 practices over a 3-year time period is what you're looking at, and around some of the diabetes measures. So programmatic level here. This next slide is a different program. This in Colorado has about 60 practices participating at this time point, close to 5,000 patients, and again, it's looking at how the practices themselves and the coaches are moving towards some of these goals in the clinical quality measures. We get asked quite a bit in terms of what does it really take in beginning transformation and thinking about transformation. What do we need to have in place? And what I tell practices, there's 4 key things. The first one really being leadership, and leadership in the patient-centered medical home, it really asks practices to do this in a new way and at varying levels. So leadership is absolutely key. Teams we talked a lot about, and this is teams that are operating at the highest level of licensure, the highest level of their profession, so that they can be as effective and as efficient as possible. This work takes a lot of creativity. The solutions that practices come up with, there are best practices available, but the solutions, are really different by practice, and a lot of that has to do with the populations that you serve. So a ton of creativity and courage is really needed to begin your transformation journey. And the other thing that I tell practices is, talking the talk is one thing, but really being able to walk the walk and be the change every day for every patient is just so important. So those are some of the main concepts that I think are really key as practices begin their transformation journey. So that's all I have, and at this point I think I'm going to turn it over to Joe and see if there might be any questions.
Yeah, we've got a lot of great questions coming in. Before we start tackling them, I just want to remind all of our attendees that you can ask your questions by typing in the chat area on the left-hand side, and we will answer them as they come in. So while we have your attention, Chase, why don't we go with a couple questions that were asked to you. The first is, what's the minimum size of a patient population needed to have an effective medical home?
So the question is effective size of a patient population. From my experience, and I would let Dr. Shore or Leah even answer this, because from my perspective, I don't think it really matters. From our perspective, we're working with a very small community where I'm at here in Mariposa today, and then we have very large practices as well with multiple providers and university-sized type panels. So, for us, I don't think size is necessarily a qualifying or disqualifying factor. I think there are different, there's nuance in terms of the implementation and what might be a little bit different in terms of size. But I think it can be done with a smaller size type practice or panel or population versus a large.
I think if I were going to answer that,
add anything?
Yeah, I think if I were going to speak to that, I would say at least 3 full-time providers and probably at least 4,500 patients to start with. I think if you go too much smaller, it's hard to figure out how to pay for the care manager and some of the other elements of the team. So it would be, I think, more challenging for a solo practice to do this, although they could. But I think in terms of a minimum size, yeah, at least 3 docs.
Okay, great. Chase, are your coaches being certified through NCQA's Patient-Centered Medical Home Content Expert Program now that it's available?
Yeah, great question. I appreciate that. So some of them are. Health Teamworks really tries to not, choose one path or another in terms of those recognition. I think for us currently, NCQA is, from the primary care side, one of the ones that we do have a lot of demand for. So we do have coaches on staff who are going through that. But we're starting to find practices who are more interested in going down the Joint Commission recognition program. So Health Teamworks doesn't necessarily recommend one over the other, but we will support practices in whatever path they're moving towards.
Okay, great. And can you just talk briefly about what the role of a QI coach is?
Yes. So there's a couple of different models, and I think I'm going to talk mostly about what occurred in Fresno, and since Leah had presented that one. So we try and do a collaborative coaching model where that person would come and get some training from Health Teamworks, and then over the course of the first year or longer, Health Teamworks would continue to mentor that coach while they're doing the implementation with their local practices and their local system. A quality improvement coach, what we recommend is that they're meeting with quality improvement teams at each practice, minimum 2 times a month. It might be more based on what they're doing, but the quality improvement coach will go into those practices, attend quality improvement team meetings, and basically try and help prioritize some of the issues. So if a practice wants to be focused on, let's say, a diabetes measure set and improve, I'll use the example of microalbumin screening. If that is what the practice wants to work on, the coach will help facilitate, moving that forward. So practices and systems really need to help develop what the goals are, and the coach's job is to really get the practice to move and achieve those.
Okay, great. We have a couple big picture questions that I'll throw out to all of you. One participant says, these concepts are mainly directed at large groups. I'm a solo practitioner with 1 PA and 2 MAs. Can this work for me? A social worker, a care coordinator, quality coach? Any suggestions for an approach?
I can take that one. So this is Chase, and absolutely we work with every size of practices, and in Colorado we definitely have that combination of single provider practices, and the challenges are different. There are advantages and there are challenges to each scenario. I think some of the advantages for solo practitioners is that there isn't you get to make your own decisions in terms of how quickly you make decisions. So that's one of the nice things about being a solo practitioner in this. I think there are less people to delegate items to, and so finding the time, it can be much more challenging. But the items that were presented today in terms of having a complex case manager, having a quality improvement coach, what we generally see or can see is that in those smaller practices, those tasks are taken on amongst the people that you have available. So it can be done. It just ends up, it ends up being a little bit of a different delegation scenario of who's doing the work.
I would add to that I think other options are for several small practices to band together and share a resource. But it helps to have probably an overarching organizing entity, and in our case it happens to be an IPA in our town, but it could be other entities as well.
I was going to add the same, this is Leah, I was going to add the same thing, that I think that it's possible we see patient-centered medical home success stories in every context, but I think that there would be a lot of advantages to having a regional project, having a learning community, sort of having the conversation with your payers as a group in your region, and CAFP would be happy to work with you on that, on developing a regional project.
Okay, great. How does your model account for populations with many different cultures or language needs? What are the adjustments that need to be made? Examples given: WR team roles, data reporting, data analyses, etc.
So I would say that that's going to be, I mean, from a practice perspective, it's if you know your patients, you'll adjust your practice to meet your patients' needs. In San Francisco, of course, it's a very diverse community, and part of the way that we meet that is we have a very diverse staff with considerable cultural and language flexibility. I don't think that you adjust your data, though. I think the goals are the goals. How you achieve those goals, that's the cultural sensitivity and language part, and that's the challenge to each practice. But the goals remain the same.
All right, great. There were a number of questions, Dr. Shore, for you based on your experience. First one is, how did you go about training the medical assistants to take on expanded roles?
That started in my previous private practice about 5 years ago, and we basically had an all-practice retreat where we talked about the concept of patient-centered medical home, and then we broke it down to the things that we thought we could do first and got input from everyone in the practice. And so we chose, the proverbial low-hanging fruit and practiced that first. So the first thing that we practiced was developing the care planner and the huddle. And that took several months to get that straight. And I think that's a good place to start. And everything else, kind of builds on that. And the medical assistants, I think, were actually excited to take on the expanded role. It made their job both more challenging and more interesting. And I think with a more challenging and more interesting job comes better compensation, so you have to be ready for that part as well.
So that was actually a question. Did you change physician compensation for the new model, or any compensation?
So physician compensation goes back to payment reform, which Leah talked about. In our particular model, yes, I went from being in private practice to now being a salaried employee of My Health Medical Group, which is a subsidiary of Brown & Tolan. And we did it that way because we knew we were going to spend an awful lot of time on development, and that would cut into traditional revenue of fee-for-service and face-to-face. So I think going forward, once you can demonstrate that you can produce in terms of population health management and patient access and satisfaction, then you can begin to have that conversation with the payers about how to recognize that value by improved payment.
And how much of your time, or what FTE do you dedicate to developing and managing the patient-centered medical home?
I describe my job currently as 0.75 clinical and 0.5 developmental and management.
Okay. What was the starting cost for Brown & Tolan?
The starting cost, it's probably several things that are broken into that. Number one, they chose to develop a brand new space rather than transforming an existing office and an existing practice. And I think that increased the cost a lot more than it would be for other locations. So if you eliminate how beautiful our practice is and look more at the consulting cost and the amount of time put into this particular practice, it's probably on the order of $200,000 to $250,000. And we take care of about 4,500 patients right now.
Okay, great. You mentioned being able to sort of demonstrate the value, and I believe Leah mentioned that the Fresno program resulted in $1.4 million in savings. One of our attendees is wanting more information on the drill down regarding where the $1.4 million in savings came from. Can you talk to that a little bit more?
Sure. Inpatient admissions and ER visits primarily. The pilot group saw a reduction in inpatient admissions of about 16%, as opposed to the full group. So in our pilot, there are 2,700 patients. The payer has 25,000 in the region. The full group saw a reduction of 3%. So it's 16% versus 3% in inpatient admissions. When it comes to ER visits, our pilot group saw a reduction of about 10%. The full group saw an increase of about 4%.
Okay, great. There are some questions about the role of allied health professionals. One participant asked, in what ways can RNs most effectively be part of a PCMH team? How many RNs or MAs per provider are recommended?
So in our practice, the RN role is the care management, population health management role, which is both direct in terms of what we call hotspotting, finding the most at-risk patients and making direct interventions and then delegating to the medical assistants. The staffing ratio is an excellent question. I think we're going to try to stay somewhere around 1.5 clinical medical assistants per provider. And I think at that level we'll be able to use the MAs to their fullest extent. Right now we're a little bit below that, and we can feel the need for more staff.
Okay, somebody's also asking how necessary it is for a patient-centered medical home to be physician-led as compared to RN or nurse practitioner-led, and they point out they think it would be less expensive to use RNs and Ps.
So this is Chase, and I can answer that question. I think it is important in the implementation aspect to really have a provider-level champion involved. There are so many aspects around evidence-based guidelines and really clinical decision-making that the provider level does need to be involved and share input and do some decision-making there. Champions are needed at every level. The reality is that every role in the office really does need to be represented, through the implementation of this work. And I think based on availability, the provider is key, but it doesn't have to be a really time-intensive type of role. We do have providers who are very much engaged and want to be involved at that level, and I think those are successful, but then we also have practices that can't necessarily put that much time, and so they're more at a decision-making, they're more of a decision-making type role than an active member. But having providers is really key in this process for many of the decision and kind of clinical areas that the model really asks practices to look at.
I think in our practice, the leadership is somewhat diffused. There are many different things that you can lead in, and we have smaller teams within the practice that are showing leadership. The clinical medical assistants are leading in one respect. The data analyst and care manager are leading in another respect. Our office manager is leading in another respect. So it's not one centralized style of leadership. It's really more collective. And I think that's actually worked out very nicely for us.
So in this model, are PAs seen as more as primary care providers or more as ancillary members of the care team?
Well, my personal view is that there's a lot of different solutions to that. It kind of depends on the culture within your practice. Historically, I was in a co-practice with a nurse practitioner, and basically it was patient choice which one they saw. I think in our new model, we're going to try and structure the care a little bit more along the lines of practicing that at the top of your license, so that we may see a shifting of responsibilities with a lot of blurring of lines, of course, but shifting of responsibilities so that the PA or NP would be doing more stable chronic care and the physician would be doing more unstable high-risk care.
Okay. Leah, you mentioned an online tool to support and guide NCQA application for recognition. What was the name of that support tool?
It's called the PCMH Accelerator Portal. This was designed by the California Primary Care Association in partnership with a company called Arcadia, and CAFP is going to be offering it to our members. So if you're interested in that portal, which helps you move towards NCQA recognition. If you're interested in that portal, contact me.
Okay. One participant was under the impression that third next available appointment was required to be a 0 for NCQA recognition. And I guess it was suggested that was not the case. Could you please clarify?
Well, so as we went through the process, we got the distinct impression from NCQA that mostly what they wanted to see is that we could measure things and start the CQI and transformational process. So we didn't have to show that we were zero right off the bat, and we got points for that. I mean, zero would be great. What we're trying to do is to balance high access versus keeping busy. If you have 100% access and no patients, that's not where you want to be. So we kept continually trying to balance between those two needs of the practice. But I don't think you have to be at zero to qualify. I think it's more that you have to be able to show that you can measure it and show that you have a process to address it. Chase, would you agree with that?
Yeah, and the NCQA scoring around a lot of those access elements, you get credit for varying levels of being able to prove those things. So, it's the NCQ application is not as black and white as that. You get points for kind of being able to prove it and being able to show data and being able to prove that you are attempting to look at access issues and meet your own goals around what you want your open access to look like.
Okay, well, it looks like we have one more question, and that's about as much time as we have. And this question is, what steps have you taken to find a better balance between follow-up and acute access?
Well, I can answer that in one specific region, which is hypertension follow-up. We're at the beginning of a project where we'll be following a fairly defined protocol, actually borrowing from the work done at Kaiser, that will make it easier and easier to get to hypertension control very quickly without very many face-to-face visits. Now, it does depend on phone outreach and ultimately on the portal outreach that will allow the patient to participate in their management without having to come in the office. And that I think that's great from a consumer standpoint, but when you're paid fee for service, it doesn't work out so well. So that puts you back into the care management fee, maybe risk-adjusted capitation type of compensation. But that's an example of how you can rebalance.
Okay, great. There's actually one question I missed, which is for Chase. For folks who are interested in potentially working with Health Teamworks, should they contact you or visit the website to find out about pricing?
Yeah, I think what I would like to recommend at this point, Leah had mentioned the relationship between the California Academy of Family Physicians and Health Teamworks, and Leah's contact information was given on the slide deck. So I think at this point I would like to have folks maybe contact CAFP, and through our partnership we'll be able to address those requests.
All right, that sounds good. Well, I just want to thank all of our presenters again. You guys have been a fountain of information, and this has been a terrific webinar, so thank you all very much. Any final comments before we wrap up?
Thank you for having us.
Thank
You're
you very
welcome.
much.
Yeah, thank you.
All right, well, to those of you who attended today, thank you for joining us. The ACCMA is regularly presenting webinars, so we encourage you to check out our list of upcoming programs at www.accma.org. Thanks again to our presenters, and with that, you may now disconnect.